Thank you for staying with us. It is still the conversation here on Lagos Television, and today we are turning our focus to a very, very important matter, and that is midwifery and qualitative healthcare in Lagos. You know, midwifery and qualitative healthcare in Lagos. Now, midwives remain the front line of maternal and child health care, providing support before, during, and after birth. This is a very important role. But we'll be talking about some of the challenges. We're going to be talking about the level of, the healthcare system at the moment here in Lagos. And of course, we'll talk about the way forward, what more can be done to ensure that Lagos residents enjoy perfect service delivery. Joining us on the conversation this morning, we are joined by Dr. Funmi Ige. She is the Lagos Team Lead Implementation for Maternal Newborn Child Health Project. And also we have with us Bola Adeleke. She is the Director, Nursing Services, Lagos State Health District 1. You're welcome, ma'am.
Thank you very much.
Thank you for joining the conversation. So when we talk about qualitative health care in relation to midwifery, what exactly does that mean for Lagos residents? Let me start with you.
Okay, thank you. I'm glad to be here on the program. Yes, qualitative care for Lagos residents and midwifery. I say that is the crux of the matter. The midwives are frontliners as far as healthcare delivery is concerned. You cannot walk into a health facility and you want to give birth and not be attended to by a midwife. So, and Lagos State, we have a lot of hospitals, secondary health facilities, primary health care facilities in the state, and they are all filled with midwives. And May 5 every year is commemorated as the International Day for the Midwife, and this year is no exception. There's a focus on midwives. We are celebrating them. We are also recognizing their role and supporting and encouraging them to do more for residents of Lagos State.
Talking about their roles, celebrating their roles, they're the frontliners when it has to do with delivery, healthcare, taking care of children. How important are the roles of midwives? You are a nurse now. Tell us, let us know, seeing it from your own lens.
Thank you. Thank you once again for having me. Having a midwife as a front line, especially when we're talking of delivery, it goes a long way, because right from who is a midwife at the first discussion is that somebody that has been trained in a qualified institution, trained, licensed and certified, and then by the Nursing and Midwifery Council of Nigeria, has that certificate that can be, presented to be able to know that this is actually a skilled birth attendant. So a midwife is a skilled birth attendant, having gone through the training, yes, specialized training. And also midwife is also a specialized care. As we have in the general practice, we have general nursing, which is the basic. But when we are talking of midwife, a midwife is somebody that has specialized care in caring for women of reproductive age, antenatal, during pregnancy, in labor, even after labor. And if you look at a midwife, we are not just looking at that delivery aspect alone. We are looking at what happens even before conception. So the reproductive period is taken care by a midwife. I was talking of their roles. Their roles, they're immeasurable, they're unlimited. Because when we're talking of a role, a midwife is trained to identify danger signs in pregnancy. And then having known this role, we'll be able to know what are the action, what are the next step, what are the things I need to put in place to ensure that this woman have a safe delivery. Because at the mindset of a midwife is that no single woman must die while giving birth. And then having that in mind, you want to do all possible best. Probably to know when to refer, if that is beyond the limitation, and immediate care of even the newborn. So it goes along role in labor, role during pregnancy, role after delivery. Even the baby. We are talking of the baby being born. We talk of helping the baby breathe. It takes a midwife trained to know what are the steps I can actually do. Because if you look at midwife, people look at the midwifery as just for the baby to come out. But it's far more than that. What if this baby comes out? What happens next? And that is why we are talking of reduction in maternal mortality. You see a lot of complication after delivery. But this midwife has been trained to even have a pre-knowledge of what will happen. So she's already prepared to be able to handle this baby and the woman. So immediately the baby is born, the baby is not responding, she knows what to do. She knows when to escalate, when to call for help, and to take action.
In terms of maternal, newborn, and child health in Lagos, how far has the state gone?
Well, one would say that the state has done well, is doing well, and we hope that the state will continue to do well. Of course, there's always room for improvement. So we look forward to the state government doing much more than they are doing already. But we must say that Lagos State has done quite a great deal. They've put measures in place. We have skilled birth attendants. Both the nurses and other health workers are trained. There are a lot of maternal programs that are in place. There's one by Her Excellency, the First Lady of Lagos State, Dr. Mrs. Ibijoke Shomolu, Jumejilo, for multiple births. That she puts just from Jumejilo, more than two. So for multiple births, she has a program in place, how to support those women in that category and ensure that they give birth well. And there are a lot of other things that the government has also put in place. Talking about traditional birth attendants, they are there, we can't throw them away, but the government has integrated them to the healthcare delivery system in such a way that they are regulated and they are trained and to know their limits, to know when to say, okay, this one is beyond us. And I'm happy that government did that, because if you keep saying no, they shouldn't touch, they shouldn't touch, people still go to them and patronize them. And if they don't handle them well, we'll be having losses. So the government has integrated that. So there are a lot of things the state government has put in place that is working, and we want to encourage them to keep doing more.
In terms of regulation for the traditional birth attendants, how well are we doing in that?
Well,
or monitoring?
Yes, on monitoring. Yes, I am aware there is this traditional board. Yes, a board. So yes, they are monitoring, and those who are found on the wrong side of the law are sanctioned. But I think it can be better, because one or two of them still escape. You know, when I work in a secondary facility, by the way, by the time we see patients that they have mishandled and not managed very well, and you find out, where are you coming from? Some try to be protective, some come out, and you are wondering, with what the state government has put in place, where are these kind of facilities or organizations still there doing what they are doing? So monitoring, I think we can do better. I think the state government can do better. But we need people to speak out.
Okay. All right, still talking about maternal child health right now. You said something about the roles, you talked about the roles of midwives and how important they are before, during, and after delivery. But let's now talk about maternal mortality. That's still a great concern, not just in Nigeria, but globally. World. Yeah. And as someone who is always in that delivery room is a powerful room, you know. What are the major causes of maternal deaths that you still see occur today?
Okay, when we're talking about maternal mortality, we have a lot of causes. But the major causes of maternal mortality has been traced down based on research and evidence-proven cases. We observe that the major cause of maternal mortality is postpartum hemorrhage. And then
can you break that down?
That is postpartum hemorrhage. When we're talking about postpartum, we know postpartum means after delivery. So when we're talking about postpartum hemorrhage, we're talking of a bleeding after delivery. We have the primary and the secondary. Of course, the primary is the one before 24 hours, while the secondary is after 24 hours. And we're talking of postpartum. in terms of bleeding, either equals or less than between 500 mils. But that cannot be judged. We can actually say 500 because it depends on individual. Somebody can just lose 300 mils. And that is why the observation and the skillful technical knowledge of the midwife comes in. Because a layman may just tell a layman until this woman loses maybe 500 mils and may be waiting until it gets to that level. But we now have a kind of an assessment, knowing fully well that probably a woman that is anemic, not having enough, can just lose about 200 or 300 and just go there and maybe thrown off balance. So postpartum hemorrhage actually occurs and is the major cause. And sometimes the major causes of the postpartum may be uterine atony. That is, the uterus after delivery is expected to contract and go back to its pre-gravid state. They also have trauma, probably tear, can cause we have thrombin, and have some laceration. And then if, having known that postpartum hemorrhage is the major cause, there have been a lot of trainings, training that have been conducted severally. So I think I want to give it to our governor, Babajide Sanwo-Olu. He has actually tried, and then it's part of the focus. Maternal mortality is on the heart of our governor, and then a lot of things have been put in place, especially training of the midwives on the management of postpartum, identification, prevention, and the management of postpartum hemorrhage. And we talk of the current training, emotive bundles, which is now the core package bundle that has been put in place to ensure that postpartum hemorrhage is prevented and also managed. So the major cause is postpartum hemorrhage in the
after delivery.
Yeah, if I may add to that as well, in addition to postpartum hemorrhage, which is the leading cause, actually, is the #1 cause globally, much more so in Nigeria. There are also complications resulting from hypertension-related causes. You have women developing hypertension during pregnancy, and if it's not well managed or controlled, it gets so severe, and they go down. Some present early, some don't, and then if they are not well managed, we end up losing them. But that postpartum hemorrhage is a very major concern, and that is where that project that for which I'm a team lead in Lagos, comes in. PPH, that's the postpartum hemorrhage for short, having been identified as the leading cause of maternal mortality. And it's preventable. That's the painful part of the whole matter. As much as PPH is the leading cause of maternal mortality, it is highly preventable if we act promptly. To act promptly, you must be able to identify, detect it early that, okay, this is a problem, or this is a high-risk patient that is prone to that and all that. So that's where the training comes in. And like I said, our midwives are the frontliners in this battle. They are usually the first point of contact between the patient when they come to any facility at all, be it public or private. They are usually the first contact, and what they do matters and determines the outcome for that woman. So that's where this training has come in. There's this WHO endorsed intervention package. We call it E-Motive. E-Motive is an acronym for E, just as spelled, E, and then the word motive. E standing for early detection. M standing for massaging the womb or the uterus. You do that to help the womb to contract. When the womb contracts, it will not push out blood out like that. And then there are drugs we call oxytocin. Midwives know about it. They are trained to administer it. They are trained to give it an injection called tranexamic acid. They give fluids to help replace the woman lost blood volume, and then they escalate. Escalating is knowing when to call for help. Oh, this one is beyond me, or while I'm doing this, let a more trained hand come in. That's where the doctors will come in, or the obstetrician, or any other skilled professional to come in. And then one other thing again concerning PPH is, like she said, you must be skilled, trained to know when the woman has lost up to 500 mils. And then, but that is objective. The way I assess, I may just say something like, this blood is much, oh, it don't plenty, oh. Meanwhile, it's not much. So we need,
to
so
be
you have to be skillful, one, and then two, we have now come up, we have to be scientific in the way we do things. So the WHO has come up with what we call calibrated drips. Okay. So by the time the drips are calibrated and your drip is soaked, it's calibrated, you can tell, oh, this is 100, this is 200, this is so and so, and then you know when to intervene. Mm-hmm. So experience also come in, and that's where this training and skill also is there. Like she said, a woman whose blood level is already on the low side, and then she's bleeding. I'm not going to wait for 500, even though the books say 500 is people. So I'm not going to wait for. That's where experience comes in, and training comes in for the midwives.
The causes of maternal death that you have talked about now, let's now link it to the importance of antenatal care, because we can't have this conversation and not talk about antenatal care.
Antenatal care. This is the care, as the name implies, ante. That is before. So antenatal care is care or management given to pregnant women, and then it's advocated that it is expected to start early enough so that risk factor will be identified early and prompt action will be taken. Then during this process as well, we have what we call GANC now in Lagos State, that is group antenatal care. The group antenatal care is a kind of care that you give to them in groups. Unlike those days that you see them all seated and be shouting, they'll be shouting, everybody will be rowdy, everywhere will be rowdy. No, we have what we now call group antenatal care, whereby you group them according to their gestational age, and then they are able to speak with one voice. They're able to speak with one same symptoms that they are undergoing. A person that is just within maybe the first trimester, the concern then is, I'm still in the first trimester, morning sickness. If you now put such with somebody that is about to maybe 36, they have desire, the passion there is just let me get rid of this baby. This baby should come. So their mindset is actually different. And that is why we have what we call group antenatal care now at the primary health center and all over. So it's a care we give to them to ensure that they are well managed, and then we are able to, groom them. And during the group antenatal care, there is a section we call birth preparedness. It's in sections. So that preparedness is when you bring the family member, they come together, even the husband will be invited. You want to plan. We call it birth preparation plan. And the midwife will now sit with that individual, the husband. When you are coming for delivery, how many children have you gotten? Maybe she has one larondo at home. You want to prepare for who will take care of that baby. Because if she mentally, she will not be relaxed while in labor. So that preparedness, you want to prepare psychologically. You also want to prepare financially. This time we want to know the economic status. What is this woman doing? Because at that time, she will need financial support. So at that part prepared, we want to know, when you fall in labor, how do you want to come to the facility? Do we need to plan with the National Union of Road Transport Workers to bring you? So he will have decided how she wants to get to the facility, or probably plan with any other. Who do you want to accompany you? We want to, maybe your sister-in-law, my mother-in-law, superstition. Somebody will tell, I don't want to see that woman. No, she should not follow me until I deliver. Even someone will tell you until the placenta comes out. So birth preparedness is part of the key, part of the visits, part of the contact jointly decide and then discuss with them during the ANC. So ANC is very critical. It is a period whereby we identify, where we take obstetric history, virus history, and we are so objective. We want them to be friendly while giving those history, because some of them may probably not come on to tell you. They may hide. They may hide. They may hide some. They may hide some information, knowing fully well that if I should come out, they won't allow me to stay here. So we also make it so friendly, and we make them to understand why they need to open up for their sake. I've actually gone to, because as an apex nurse then, there was a particular place I went to. This woman is about to deliver after the second trimester. Observing, because I do work with them as well. So I was just palpating. Sometimes they tell you, apex, don't worry. I say, don't worry. I'm still a midwife. So I just palpated, opened up the tummy, pulled down the pint, and I observed that this woman that had previous cesarean section done. And in the card, cesarean section, previous obstetric surgery No.
No. Oh.
I have to call her. I call her and I said, Madam, bye. This is why we want to know. That day, I gave her a referral letter. And the referral letter given, I don't just give her. Now we have a kind of synergy whereby we communicate with the secondary facility. We want them to know. And even sometimes in the presence of that client, we call. Hello, I have Mrs. Lagbaja. She will soon get to you. She's coming for this. Please take up her care. And they are rest assured. So that is the kind of management, that's the kind of treatment we give to them now at the primary health care level and across the facilities as well.
Okay, that's beautiful. I didn't know that we have.
Yes, we do.
Yes, we do that.
So even with this now that I have just heard, some people still do not go for antenatal. I mean, even in 2026, that's Ayeti. So what are you doing to, or what is the state government also doing to ensure that you have more women, more men, husbands, embrace this?
So it's health education, enlightenment, sensitization. I'm aware that at the primary healthcare level, they go to communities, they go around the communities with speakers, with vehicles, and medical evangelism kind of, and encourage people to come out. You will see this, you will hear them speaking in vernacular, speaking in pidgin English, to encourage women to go out. I hear that in my community, in my area. So that's one of the things that the state government is doing. And then when they manage to come to the facility, talks are given, general talks, so that others will hear and tell them. And then we also encourage one-on-one contact with health workers, encouraging others to, encouraging people, their neighbors, for example, to ensure that they come to the facility to register. So, and then we go to marketplaces. The medical women, that's the Association of Female Doctors in Lagos State, is one of the things we do. We go to markets, schools, religious homes, churches and mosques, to educate and sensitize people as well, and encourage them to come for antenatal and the importance of antenatal and nutrition and all those things. So even though it's the primary responsibility of midwives, other health workers are also encouraged to do them, and that's what we are doing at this time, even as we celebrate the International Day of the Midwives.
Okay. What are some of the challenges that midwives are facing currently? I know that the Japa syndrome is really rocking everywhere, and most especially the health sector. But I'd like you to talk about some of the challenges that midwives are going through.
Okay, when we're talking of challenges, it cuts across all cadres, and as well as of which midwives are also part. For the midwife, like I said earlier on, people look at midwifery as just for the baby to come out. And then a lot of other, even a layman will tell you it's just for the baby to come out, but it is more than that. The midwives have been faced with a lot of, it's like something you have bought with a very precious, your precious gold, your precious inheritance. Now looking at other people, just, having their way, to have it done. Then we'll also look at motivation. The midwives, they need to be motivated. And then looking at midwifery is a specialized care. Is a special field on its own. So the midwife needs to be recognized the more. Thank God we're having the International Day of the Midwives. And that is for us to know that something special is in that aspect of a course, or it's in that aspect of profession, of that cadre. So they need to be more recognized. And also, incentives. We are talking of emotives. A lot of them have been trained. Then there are some infrastructure that are needed to be put in place to ensure that they actually carry out their activities, what they've been trained for. We are talking of emotives. Dr. Ige said something about a calibrated drip. The calibrated drip is what we use to measure. You are able to actually estimate. We have an estimated blood loss. We have what we now call calibrated drip for estimation of blood loss. So if at every labor room, at every place where delivery is being taken, it's expected that we have that calibrated drip available. because gonna do they we want to ensure that now that we have the calibrated dip being, you know, part of what is now the standard for measuring blood loss, we want it to be available. So when the tools that are needed to be used are available, they will be able to carry out their work as expected.
Right. Are there some misconceptions that you might want to address about midwives? You know, when we were talking before we came back on the show, we were talking about one thing and everybody was laughing here. So I'd like you to address some misconceptions. I have one that I will say.
Okay.
It is believed that midwives saying,
nice, Rara.
So I'd like you to talk about it.
And the midwives, they are the most nicer, if there's anything like that. Yes, because the passion that the midwife has is, I want that baby to be alive. Do you get it? And the old practice, because I just want to chip that in now, because I have a lot of experience, I have a lot of misconception that I want to believe now. Then their mindset is to back cooperate. If anything happens to this baby, I'll be responsible. Because I would like to endorse, I would like to sign, I would like to write reports. So then they keep slapping, they keep, you know, doing all they like to ensure that this baby comes. But we now have what we call respective maternity care, which all the midwives have been trained on. What are we talking? We are talking of respective maternity care. Gone are those days now that they've come to the maternity during delivery. Oh yeah, bam! Before a midwife carries out any investigation on you now, will seek your consent. Oh, madam, I want to check the extent. I want to know the progress of your labor. Please, can you just open up? Gonna do that. It is the midwife that will open the lab herself. Now, the woman on her own will be asked, oh, madam, can you just open your lab? I want to check you. And as the midwife is checking, going into the service, because we are always on this, at the tip of their service, we are only on their cervix. So now, as the midwife is going in, the midwife say, oh, madam, sorry, I will soon be out. I will soon be out. And confidentiality too is there. Privacy too is there. We want to ensure that they want to give them comfort. Comfort, you get it, we have to rub. And that is where we have the labor care guide. We have the standard tools for, you know, monitoring progress of labor. We have labor care guide. The labor care guide has a lot of sections, whereby it's expected that this woman comes in with a companion. Gonna does it that, Kilenwa, what do you want? Now, the midwife will allow. The midwife will allow any relation, and that is part of the birth preparedness. Who will accompany you and be there with you? Because there may be more than 2 deliveries, labor cases. So as this woman is in pain, you will have taught, the midwife will have taught the companion, you can just rub the back. Because she cannot rub this one's back, rub this one's back.
Time will not permit us. We need to go.
All right, because I wanted very quickly to say that in spite of this, we must be objective and practical. There are 1 or 2 patients that are not very cooperative.
Exactly.
They are in labor, they are in distress. So once in a while, you see the midwife stretched to her limits.
Because they are all human too.
Yeah, human too. And then when the woman she's saying, madam, open up so that I can check you. The woman is close, especially when the baby is about to come out. No midwife will tolerate that. That's why they give them that part. It's not slapping on the face, but it's that time. By the time they do that, you see them open up. But then, like she said, we don't slap. That's why the antenatal conversation is very important. At that place, they are able to tell what to expect. And then very quickly to talk about the challenges, manpower shortage. Permit me to talk about manpower shortage. JACPA has widened the gap. But do you know that there is a global shortfall of midwives to the tune of 980,000 midwives globally? You cannot imagine the statistics for Nigeria and also Lagos as well. So, and that's why the theme for this year is 1 million more midwives.
So we need more people to go to school. Interesting conversation, and hearing all the things that you have said about the way midwives handle. They do person say make you go get.
Yes, now I'm expecting. We are expecting you, please.
Okay, well. For those in that WhatsApp group, they are Thank you so much, Dr. Funmi Ige and Bola Adeleke, for your time on the conversation today.
It's a privilege. Thank you for having us.
The conversation continues. Stay with us.